physiology related to your respiratory system. But today, what we're going to do is how to understand to apply it in various conditions. So respiration in abnormal conditions, a bit about how pulmonary function test can be used, and a little bit about extra ventilation techniques that can be given from outside. So let's just take a look at some of the questions that can come from this. One is about high altitude. A long essay discuss the physiological changes that occur at high altitude. And then we have shorter questions, like one can be hypoxia. It can come as part of an essay, a sub-question of that. So hypoxia, you can talk about the different types of hypoxia. And then, like we talked about high altitude, we have deep sea diving as well. Sorry. So then we were talking about the pulmonary function test. So what are the principles and then the significance of pulmonary function test? And then, miscellaneous questions like, define cyanosis and its clinical implication and artificial ventilation in clinical setting. So questions like this can be used. Apart from that, questions of COPD, obstructive versus restrictive lung disease, asthma, all of these questions by itself can come separately. Okay. So we'll start off with understanding one simple concept, that is high altitude and deep sea diving. So the thing is, if you are at your sea level, so say this is your sea level. Okay. Now, above the sea level, if this is the end of the atmosphere, and there is this much column of air, if you take this one particular point. So all the air which is there in this area, the pressure exerted by this whole column of air at this point, that will be the pressure which will be 1 atmospheric pressure. That usually comes to around 768 millimeter of mercury. So that much pressure is there at your sea level. Now consider there is a mountain over here and you climb this mountain. Now, once you climb this mountain and reach at this point, now the column of air which is above this, that is, this is the column of air which is exerting a partial pressure at this point. Say this is around, just consider this mountain to be Mount Everest, 29,900 like that, comes to around your 30,000 feet. So the pressure will drop down to 226. So you saw here how from 768, it dropped down to 226. Now, 768's 21% is the oxygen which we finally have in the air. That will come to around 150. Now, consider you're standing over here and 21% of that will come to around 47. So 47 is the partial pressure of oxygen which is there in the air. Now, from the air, by the time it comes, humidifies. So water vapor pressure takes a part of it. Dead space will be there, carbon dioxide and all that. So ultimately, at the end of that, it will reach the alveolus, which will be even further low. And after the shunt, the percentage saturation will further decline. So that is what you have to understand. From here, by the time it reaches your blood, it is around 100. Okay. Now this will be so much more lesser. This is one problem that we have to face when we talk about your high altitude, going in high altitude. On the other hand, we go down. As we go down, what will happen? This column of air is no longer this much. Say you're standing at this point. Now this is the entire column of air, right from the top we were talking about, from here till here. So now the pressure, what will happen at this point? Pressure will be so much more greater. Okay. So let's say it's 2 atmosphere. As they keep going down, it becomes 4 atmosphere, 5 atmosphere, 6, 8 atmosphere and all at some point. So here the problem is high partial pressure. So in deep sea diving, what is the problem? High partial pressure. So partial pressure, why is it a bad thing? So when partial pressure is high, too much of it is going to come into your system. So if oxygen is very high, that will result in toxicity. Excess of carbon dioxide, that can also result in toxicity. Now, there is something else which would normally not cause a problem. That is, this is 21%. The rest of it, majority of it is your nitrogen. But at high pressures now, nitrogen will come into the system, saturate everywhere, resulting in narcosis. We call it narcosis with nitrogen. So these are the 3 problems that you have when you go down and there is deep sea diving. So just take a look at this. You can see how this is 760 millimeter mercury, like I was telling you. By the time you reach 30,000 feet, it is around 47 millimeter of mercury in the air. We were talking about this. Now, you take a look at this curve. At 10,000 feet altitude, partial pressure is still above 90. Okay, not partial pressure, the saturation as a result of the partial pressure. So saturation in the blood is still above 90. When you put pulse oximeter, that is still above 90%. Okay. Can you see here from 10,000, it's gone to 20,000. This is just 10,000, not much. From there, you're going to 20,000 feet. This partial pressure has now dropped to 70%. Remember, at 30,000 feet, it was 47 something. Now you can see that by the time it reaches around 23,000 feet, partial pressure has dropped to 50%. That means RBC is only 50% saturated. What will that do? The arterial blood, usually saturation is above 97%. Even at the level of veins, capillary, the vein. So at that point, usually at 40 millimeter of mercury, it goes to around still 75% saturation. But here, what will happen at 23,000 feet? Even the arterial oxygenation is less than around 50%. That becomes problematic. The problem is air won't be there. Okay, so this is what it does. That is hypoxia. Now, what is hypoxia? So ultimately, what will happen? Oxygen is not there. Okay, when oxygen is not there, and not enough partial pressure of oxygen is available at the tissue level, that is what we term as hypoxia. Hypoxia can be of different types. This particular type is what we call your hypoxic hypoxia, where outside partial pressure is less. As a result of that, at the level of tissue, it becomes less. That is hypoxic hypoxia. So what are the acute effects as a result of hypoxia? So when you reach around 12,000 feet, you start getting headaches, little drowsiness, fatigue, and all that. You keep going, and acute hypoxia at 18,000 feet can result in seizures. And at 23,000 feet, we were just seeing how it is 50% saturation. You can even go into coma. So one of the most profound things that you notice about your hypoxia is there is decreased mental proficiency. Especially in the beginning, that is one of the things you'll be able to understand. You'll have decreased judgment, poorer memory. Even the performance of your motor movements will get sluggish. So as you start seeing all this, you should realize that, okay, hypoxia is happening. So when hypoxia happens, there should be some sort of reaction by the body. So one of the things that happens is hypoxia-inducible factors. So through a series of transcription factors, so this is something we had talked about when we were talking about RBC erythropoiesis. So through hypoxia-inducible factors, we'll activate a set of genes that will activate one erythropoietin for RBC production. Vascular endothelial growth factors, so that more angiogenesis happens. Mitochondrial genes for energy utilization, glycolytic enzyme, because we are considering that there is going to be a situation where hypoxia is going to happen. So anaerobic metabolism might be required. And nitric oxide for vasodilation, so that more blood flow is there. So these are all different changes that happen as a result of the release of hypoxia-inducible factors. So that is where you have to understand this terminology, acclimatization. What is acclimatization? It is a physiological adaptation to a new altitude. So I told you, whenever there is an effect, there is going to be some sort of a response in the body. That response and adjusting is acclimatization to high altitude. So what are the things that happen under this? These are the headings under which you have to answer this. So if a question of high altitude, remember this is an essay we were talking about. So these are the headings under which you have to discuss acclimatization. One, the pulmonary ventilation increases. Then the diffusing capacity, not only the ventilation, how much air is diffusing through the alveoli and reaching the other side. That diffusing capacity by itself is going to increase. There are certain changes in the blood that favor better transport of oxygen, like hemoglobin and PCV, all that. Then, apart from that, there will be more blood vessels. We saw earlier vascular endothelial growth factor, so vascularity by itself can increase. So one of the things I want you to understand is the pulmonary ventilation. Initially, there is an increase of around 1.65 times. And after 2 to 3 days, that can go up to 5 times. So generally, what is going to happen when there is decrease in PO2? We had talked about it last time. The peripheral chemoreceptors sense detect it. And that will result in increase in ventilation by stimulating respiratory neuron. On the other hand, same time, when there is an increase in PCO2, that is going to stimulate your central chemoreceptors and in turn will stimulate the respiratory neurons to increase your ventilation. So what is the primary thing that is going to stimulate? The first thing that is going to be decrease in PO2. There's something called a hypoxic drive. We had talked about it last time. Generally, your PCO2 level is what determines through the central chemoreceptors. But as you go up and your partial pressure drops less than 60 millimeter of mercury, then something called a hypoxic drive is going to kick in. And in that instant, PO2 will be the major contender over here to regulate your respiration. Otherwise, if there is a PCO2 buildup, then central chemoreceptors can also help. So what exactly is the reason why these changes happen? Immediately 1.65 times, and then chronically it becomes up to 5 times. So this is where you have to understand one component as to why this is happening. So I'm just going to draw a crude structure. Say this is your brain. Outside the brain, we have the CSF. I'm going to draw one area over here like this. This is your chemoreceptor, central chemoreceptor. Now this will be connected through a blood-brain barrier. And on one side, from the blood, you're going to have your lungs. And here I'm going to draw the kidney. So what is the problem right now? One, your PO2 in the blood is dropping. Not in a blood for your, not in a PO2 for your cells. Instead, the cells are going to release more PCO2. CO2 and PCO2 is going to increase. Now, when the PCO2 increases, what will happen? There will going to be increase in your PCO2 going over here and getting converted to H plus. This H plus is going to stimulate the central chemoreceptors, or through your peripheral chemoreceptors, the fall in PO2. Either of these are gonna go and stimulate an increase in your ventilation, resulting in hyperventilation. When the respiratory rate increases, one of the things that happens as a result of that is your CO2 goes away. And when the CO2 goes away, CO2 is a potential asset. Now the CO2 is falling. You're hyperventilating, hyperventilating, hyperventilating. As a result of that, your CO2 decreases. So when CO2 is decreasing, the amount of H plus which is stimulating this is reducing. So because of this opposing effect, this increase in ventilation is only 1.65 times. This is the initial situation. Later on, what happens? Later on, in 2 to 3 or 2 to 5 days, your kidney is going to come and help. As a result of increased carbon dioxide washout, what is happening? CO2 is declining. So acid is reducing. So what is going to happen? There is going to be some sort of a respiratory alkalosis in the blood. Depends on the rate, but still, according to that, pH will slightly increase. So since the alkalosis is there, which is respiratory induced, the kidney will try to compensate by bringing back the H plus and excreting more HCO3 minus. This is the thing that kidney does. As a result of that, the H plus will be high enough and it will not drop. And that can continue to stimulate your central chemoreceptors. Thus, after few days, it is gonna increase to 2 to 3 or 2 to 5 times. Different textbooks give like different values. So this is one thing students find it difficult to answer when asked. Now the second thing, that is your diffusing capacity. Normally, your diffusing capacity is 21 ml per millimeter mercury. DLCO is what you're talking about. Now that can increase up to 3 times. Apart from that, cardiac output also increases. Then your tissue capillarity also will increase. That is usually the capillarity angiogenesis takes a longer time, not an acute effect. Changes in the blood, one, your PCV. Normally around 42 is the value, 40 to 45 we give a range. That will increase up to 60. The hemoglobin, it says you're taking 100% hemoglobin as 15. That can go up to 20. Blood volume increases 20 to 30%. Why all this? To make sure that better transport of oxygen is happening. Because lack of oxygen at the tissue level is hypoxia. When there is a lack of oxygen at the tissue level, body tries to compensate for it by at least making sure that whatever available oxygen is transported properly. There is no shortage at that point. And then we have to talk about how separately acclimatization in natives happens. In natives, one thing if you realize, their chest size is greatly increased, while their smaller body size is somewhat decreased. So this gives them a higher ventilatory capacity compared to the body mass. Apart from that, they have a higher cardiac output. Even their heart is larger. They have higher hemoglobin. Now, how much of oxygen is given and extracted, that is also higher. And greater number of mitochondria and better ability to utilize your cellular oxidative enzyme. These are various things by which natives who have been grown up since childhood have when they are living in a high altitude. So this is one chamber that we can use, which is helpful for simulated descent. This is called a gummo bag. So as we were talking about, the main problem is hypoxia. If hypoxia is a major issue, how can you prevent that and let yourself acclimatize? Once you acclimatize and all these changes that we talk about happen, you'll be fine. Otherwise, suddenly if you go to a high altitude, then it is problematic. So what you can do is, instead of suddenly going, okay, do a slow ascent. You can use these simulated descents. For example, if you go to a high altitude more than what you should normally do, then you can come back down and stay at a simulated environment. So usually when we say about 2,500 meter to 3,000 meter altitude, when you beyond that point, when you have to gain altitude, usually try not to be more than 300 to 600 meter per day. If 1,000 meter gain in altitude is there, make sure 1 day of rest is there. Breathing oxygen helps. How does breathing oxygen help? You can see over here. So this is in stark comparison to what we were seeing earlier. If I'm at 30,000 feet, it is 90% saturated. Above 90% saturated. But if you breathe pure oxygen, even at 39,000 feet, you're still maintaining about 90% saturation. And you can see here at 47,000 feet. With oxygen, it is coming to 50%. Instead of 23,000, more than double the distance you can carry now with oxygen. If symptomatic, do not go ahead anymore. And as I was showing you earlier, you can descend to a lower altitude. If you cannot descend to a lower altitude, you can use those gummo bags and reduce the, increase the pressure to at a lower level pressure. So either you go down or you use something to simulate a environment of a lower altitude. So these are the various ways by which you can prevent this. So that is the first essay that we were talking about. Now let's take a look at the question. The primary adaptation to hypoxia at higher altitude includes, as we were talking about it, off the law, the best option is hyperventilation as a result of peripheral chemoreceptor. Why peripheral chemoreceptor? Because decrease in CO2. But the central chemoreceptors also act. Yes, of course. If that was also there, then it would have been a little confusing. But since that is not there, okay, this is the obvious answer. If that is there, then it becomes a little confusing, and they would ideally have to give certain conditions for us to answer it better. Respiratory distress at high altitude is due to low alveolar oxygenation pressure, leading to hypoxia. Next, we'll come to deep sea diving. So you take this much amount of air in a bucket and put it down, keep putting it down. As you keep going down at around 33 feet, it becomes 2 atmospheric pressure. At 100 feet, it becomes 4 atmospheric pressure. At 300 feet, it becomes 10 atmospheric pressure. Can you see how different it is? Just 300 feet. Not 30,000 feet like you go up, instead 300 feet when you go down. 10 atmospheric pressure increase can be there. As a result of that, what will happen? This volume, when the pressure outside is increasing, the volume over there will decrease. You keep going further. Keep going further. So this is the pressure it is exerting from outside. So when you are going deep, partial pressure is increasing, nitrogen, oxygen, carbon dioxide, all of this we talked about. So we have water and fat. So into the water, it will get dissolved, or it can go into the fat as well. Especially things which are fat-rich, where lipid content is higher. One example is the neuronal membrane, which has a higher lipid to protein ratio. When the partial pressure is increasing, it gets saturated into this, considering you stay there long enough. We just go in and suddenly come back, there is not enough time for that high partial pressure to dissolve everything into the system. But if you continue getting submerged at high partial pressure for a long period of time, then those 3 things I was talking about is going to happen. So what are the things that happen? Nitrogen narcosis. So you go to 120 feet, you'll see that the person is starting to feel jovial, very happy. Around 150 to 200 feet, the person is going to start getting a little drowsy. 200 to 250 feet, he becomes pretty clumsy. And more than 250 feet, he becomes useless. So it's actually pretty similar to how you have alcohol. And this is actually something called Martini's law, where each 15 meters of depth has an effect of drinking an additional martini. So the neural membrane, which is high lipid ratio, that can now, because of the effect of nitrogen, can alter ionic conductance and cause problems. That is why this is said to be happening over here. That is with regard to nitrogen. Apart from that, we have oxygen toxicity. In an acute situation, oxygen will most likely lead to brain dysfunctions. Acute oxygen can result in seizures, nausea, some bit of musculo-neural problems like muscle twitching, dizziness, visual disturbance, irritability, disorientation, all of this can happen. In a chronic setting, a more of pulmonary disability can be seen, with pulmonary edema, airway congestion, and can eventually lead to collapse of the lung. And apart from this, oxygen by itself, high oxygen content can result in free radical formation and result in damage. So these are the problems in high deep sea diving. Now, Normally it's difficult to get a lot of carbon dioxide because the percentage of carbon dioxide is less. Okay, nitrogen is, 78%, 21% is your oxygen. It still makes sense. Carbon dioxide, not much, unless, certain apparatus that you use will result in very high dead space for breathing and all. If it's not put properly or dead space is high, then you can end up having carbon dioxide toxicity. Now, usually up to 80 millimeter mercury, it can be tolerated, but beyond that, when it goes, you have to understand that although carbon dioxide stimulates the chemoreceptors, direct effect of CO2 is to depress respiration. PCO2 through H plus indirectly can result in changes in your chemoreceptor activity. But if direct CO2 is there, that can depress it. Okay. So that is the effects. So you have to understand, students always get confused. Look at the question properly. If the question is, what are the effects of deep sea diving? Then what we were talking about right now is a problem. Nitrogen narcosis, oxygen toxicity, carbon dioxide toxicity. Caisson's disease, that is a separate thing. When we are talking about Caisson's disease, the prerequisite is the person has been down long enough for enough saturation. And then he's suddenly ascending up. So from an area where there is high partial pressure all around his body, he's suddenly going to an area where there is low partial pressure. And this is not only in deep sea diving, any condition where something like this is happening. For example, a pilot is flying in a pressurized chamber. Suddenly that pressure is gone. So you're going from a high pressurized area to a low pressure area. Say, for example, you are in a spaceship and it is pressurized inside. From there, you're going outside to a low pressurized area. So as I'm saying, it is not only limited to deep sea, but anywhere where high pressure to a low pressure changes happen. So high partial pressure, both fat and water, it is saturated. Now from here, suddenly the person is going out. So the partial pressure of, all nitrogen, oxygen, carbon dioxide is high inside fat in the water, but is low outside now. So what is going to happen? From the water, it will start coming out. From the fat, it takes a little more time once it's saturated. And more often than not, it can result in bubbling, a sudden change in partial pressure, and it can come out as bubbles. Those bubbles can cause problems. Around 85 to 90% of the problems are seen to be in joints and muscles. 5 to 10% in the nervous system. 2% can affect your respiratory system. These bubbles can cause respiratory problems. Otherwise, most likely it's joint pains, muscle pains. Sometimes, nervous system abnormalities can be there, or a respiratory problem. And major problem is nitrogen. Nitrogen in your normal partial pressure does not do anything. But in a pressurized chamber, deep sea, it is fully saturated. Now the nitrogen is trying to come out. Such a drastic difference. And the percentage is so much higher, 78%. Okay, so this is what happens in your Caisson's disease. And I was telling you earlier, divers, pilots, all of this, any sort of wave from where a sudden change from a high pressure system to a low pressure system is the problem. So how can you prevent this? Low ascent is one of the things that you have to do. So say, for example, more than 190 feet, more than 200 feet, if you're going, you'll probably have to spend 3 hours to come back. So you do a work for 1 hour, you stay for 1 hour. To come back up, you need to take 3 hours. So that is the amount of difference you have to understand. Now, you can use a gas tank to give more of oxygen. So most of the problems here is because of your nitrogen. So what you can do is you can instead give a mixture of oxygen and something else. Why a mixture? Because high oxygen content can result in oxygen toxicity when you go. If you give 100% oxygen and you come down, and that 100% oxygen will result in oxygen toxicity if you're going to stay a long time. So you need to mix it with something. Nitrogen is problematic, so you go for something else, that is helium. Why? Because it has only 1/5 of the narcotic effect of nitrogen. One. It takes up only half as volume, dissolves in the body tissue. And it has lower density also. So airway resistance is very minimal for breathing through this. Use a scuba, self-containing underwater breathing apparatus. Abbreviation of that is often asked in exams. Self-containing underwater breathing apparatus. So it has a cylinder, the valve at that stage. So that helps it stay in a pressurized form. And once it is taken, it goes into a low pressure form. And then we have a mask with a demand valve. So as you So this is how your scuba is going to work. The only issue is it's limited. You can't keep using it for a long time. You will run out of it. There's only limited time. You can use scuba and go inside. One of the things in decompression that you can do is in disease is decompression sickness. You can give hyperbaric oxygen. What is hyperbaric oxygen and where else can you use it? This is also a short note that comes. So you give a higher pressure, usually around 2 to 3 atmospheric partial pressure, you give only oxygen. Now this for a very long time is usually not good, but in certain instances, it can be helpful. One is your decompression sickness. So in a way, what you're doing, you're putting everything into oxygen instead of, nitrogen being a problem, and it is going into, oxygen, and you're giving it in a higher pressure. So whatever is there, it'll take time for it to come out. Similar way, it can help out in carbon monoxide poisoning. Under high pressure, there is higher chance because carbon monoxide has higher affinity. Oxygen cannot combine to hemoglobin where carbon monoxide is there. But under high pressure, it can go in. Apart from that, in an environment where 100% oxygen, because of its free radical and the nature of oxygen at high atmosphere, can be used against Clostridium for gas gangrene. Also, it has been used as an adjunct therapy for osteomyelitis. So take a look at this question. Primary cause of nitrogen narcosis during deep sea diving is increased partial pressure of nitrogen at the high barometric pressure. So next we'll understand what is hypoxia. We were talking about hypoxia. I was talking about it earlier, a lack of oxygen at the level of the tissue. There are different types of it. We have hypoxic hypoxia. What is hypoxic hypoxia? If the problem is less PO2 outside, as a result of which hypoxia is happening. And then we have anemic hypoxia. This has something to do with your hemoglobin and how much of oxygen can go into that system. Stagnant hypoxia means whatever is combined in the hemoglobin, if it's not transported till the tissue well enough, that is stagnant hypoxia. What is histotoxic hypoxia? Finally, it reaches the tissue, but tissue is unable to utilize the oxygen for some reason. That is histotoxic hypoxia. So you have the respiratory tract, oxygen coming in, either oxygen is less outside, or some problem in the airway where oxygen is not being transferred well enough, or from the alveoli to go and reach the circulation, diffusion. So in any of this is affected, this is called hypoxic hypoxia. On the other hand, if hemoglobin number is less, or there is some CO poisoning, as we were talking about, this can be anemic. There is not enough hemoglobin, or the hemoglobin which is abnormal in nature, or carbon monoxide poisoning is there because of this high affinity is not allowing oxygen to combine to it. So this will result in anemic hypoxia. You can see here, this is the oxygen hemoglobin dissociation curve. Usually when there is less hemoglobin in anemia, you'll see a shift to the right. But instead, at 14 gram per deciliter, no anemia. But 50% carbon monoxide is there. You'll see instead a shift to the left. That is because of difference in the affinity as a result of that. Which of the following is a characteristic feature of hypoxic hypoxia? This is pretty simple. In hypoxic hypoxia, what is happening? PO2 is reducing. And that results in reduced oxygen saturation. Now, apart from that, we next have to go to stagnant. So this RBC from this point should go and give it to the tissue. If for some reason circulation is affected, that is stagnant hypoxia. This can be a localized problem where there's some sort of obstruction or some tissue edema, or it can be a circulatory. Serious problems can in turn result in this. And finally, to reach into the system. One thing, because of cyanide, cytochrome C oxidase, which is needed for your Krebs, after Krebs pathway, the TCA cycle, the oxygen is not being utilized to give energy. Any deficiencies or anything that blocks the cellular oxidative enzymes like this. Or even your vitamin B1 deficiency resulting in beriberi, that can by itself result in hypoxic hypoxia. So how can you treat this? Generally, most of the other ones giving oxygen is one of the things. Hypoxic hypoxia, definitely oxygen. Unless, respiratory obstruction, you have to open it up. Otherwise, mostly oxygen will help. Even for your anemic hypoxia, if you give good enough oxygen, there the problem is you have to treat the carbon monoxide poisoning, where you can give hyperbaric oxygen, or you can treat the anemia. But oxygen helps. More oxygen, gradient means more oxygen can somehow combine and be transported. Stagnant also, same. If you give more oxygen, it does help to a degree. But ultimately, you have to correct whatever problem with the cardiovascular, general, or local problem, whatever is there, has to be treated. Histotoxic is one thing, it doesn't matter. Oxygen therapy is of no use because it doesn't matter how much oxygen we're giving, the tissue is not able to utilize oxygen. So how will you treat cyanide poisoning, for example? You can give hydroxycobalamin. So that converts cyanide to a cyanocobalamin, which is much more manageable, not as poisonous. You give sodium thiosulfate. Cyanides can ultimately be again converted to thiocyanate. So you're reducing how bad it is. You can give sodium nitrite. So the hemoglobin will be converted first into methemoglobin. So now when cyanide acts on methemoglobin, it becomes cyan methemoglobin. Again, we are doing damage control. That is exactly what we're trying to do over here. And then we have oxygen therapy. Normally, we have 21% saturated oxygen. When you give 100% oxygen saturation, one of the things that is going to happen is you have, your alveolar air has 100 millimeter of mercury. From 100, it will rise as to 600 millimeter of mercury. Because of that, that will now create a gradient from 60 between the artery and the alveoli to 560 millimeter. 100 and 40 between that. Instead of that, it will go to around 560 millimeter, around 800% times increase in the gradient. This can be given by various mechanisms. Oxygen therapy sometimes I've seen as a short note. You can give your nasal prongs, mask with ventilation. There are tents which are available, rebreathing mask, non-invasive ventilation, and invasive ventilation. So this is something you rather come across, especially during that COVID times. We can use a nasal cannula like this. So the nose will be attached. You can give a face mask and give ventilation through that. There's something called a reservoir mask like this. There can be a rebreathing system over there. A high nasal flow, like a cannula, but something that can give much more higher flow rate. Then there is something called a CPAP. You put a mask, and the mask creates a suction and positive pressure, which can be adjusted using a ventilator setting. Or if nothing helps, you have to put a tube right down and directly ventilate it, put it into the trachea. So oxygen therapy is contraindicated in which of the condition? So this is something you have to understand now. The thing is, in certain situations, if CO2 is less and CO2 is a little high because of some problems in the lungs. So the person eventually adapts, the chemoreceptors adapts to that level of CO2. And that is one of the things that is resulting in a respiratory drive for the person. If, for example, you see a person, especially with COPD, you see a person with COPD, he comes complaining of difficulty in breathing. Say his partial pressure of oxygen is coming to 70%. Now you give him oxygen. It reaches 88%, 88, 90%. You shouldn't be like, okay, normal person is 97%. Let's keep giving him more and more oxygen. That is not something you usually do in a condition like COPD. Why? Because COPD is a chronic condition. There is problems with oxygen, and he'll usually have a higher amount of carbon dioxide. And the body is adjusted to that. And one of the reasons why his normal ventilation is working is because of the drive, because of the carbon dioxide, stimulating the central chemoreceptors. Now, when you give oxygen and you overcorrect it and make him go to high saturations to the point that PCO2 drops, that is in fact reducing the respiratory drive in the person, which he was so used to having. And that can be a problem. So, of the lot, this will be the answer. It's not that oxygen therapy is contraindicated. That is, not at all what we are talking about. It's just that when he's having, hypercapnia, more PCO2, and now he's having a respiratory failure, whatever drive he's having because of the PCO2 will be eliminated if we give a lot of oxygen. That is what you have to understand. Not that you don't give oxygen. Now another question, what is cyanosis? Cyanosis is the presence of reduced hemoglobin. Normally, hemoglobin can be there in two forms, oxygenated or reduced. Now in your arterial system, we have oxygenated hemoglobin. If for any reason, in your arterial system, more than 5 grams per deciliter is deoxygenated hemoglobin. It becomes what is called cyanosis. And cyanosis can be of two types. This is an example of a central cyanosis where, around the lips, nose, your lobes, and your peripheral areas all have bluish color. But for example, if it is only this leg, this part, that means there's some local issue over here. That is the difference between a cyanosis, which is central, and peripheral. Now we talked about artificial ventilation. Artificial ventilation, how does it result in gas exchange? Generating positive intrapleural pressure. Positive intrapleural pressure will result in expiration. So this is just, if you understand mechanics, you can answer all these questions. So increasing the transpulmonary pressure. What is transpulmonary pressure? Your intraalveolar pressure minus your intrapleural pressure. Since the intrapleural pressure is usually negative, this whole value will be positive. And when it increases more, it results in air to come in. Artificial ventilation increases this. One of the reasons it does is by putting this and putting in air at higher pressure, resulting in an increase in the intra-alveolar pressure. Now, older ones are there which can even affect the chest movements. Now, when you give it like this, sometimes barotrauma can happen. When you put high volumes, either high volumes or even high end expiratory pressures. So what are we talking about? So this is your ventilator machine. So in the ventilator machine, there are certain things you can usually control. How much volume can go. For example, we have 350, 500, 1050 ml. Based on the requirement, you can increase the volume. Or there's something else called PEEP. What is PEEP? Positive end expiratory pressure. So when the person is expiring, if he expires too much, the collapse can happen. Or pathological lung, the collapse can happen. Once collapse, it is very difficult to open it up. We saw it in surfactant compliance and all that. In the compliance curve, the lower part, it's difficult to open up because of higher substantial. So in order to prevent that, always make sure that at the end of expiration, in this, you give some sort of positive pressure from the other side to keep it open. That positive pressure, if you increase it too much, again, barotrauma can happen. Or the volume that you're taking in is too much. That also can result in barotrauma. And then you can change the respiratory rate. Respiratory rate, changing it is important because if you put the respiratory rate very high, carbon dioxide washout can happen. If you keep it too low, carbon dioxide buildup can happen. So you'll see respiratory acidosis, alkalosis, and all happening in the person. Okay, so we have to always check the blood when the person is on ventilator. Do an ABG, arterial blood gas analysis, to look at how much of the PCO2, how much of the PO2, how much of the bicarbonate level, pH, and all that, and adjust these settings accordingly. Excess pulmonary function testing, measuring FEV1 by FEC. The main reason is for restrictive and obstructive lung disease. So this one diagram will help you understand what is FEV1 and what is FVC, forced vital capacity. So you know what vital capacity is. Take a deep breath and expire. That is vital capacity. You do it very fast, as forcefully, as fast as you can. That is forced vital capacity. Now, imagine this is the volume that is going out. That is forced vital capacity, maximum. Now, in the first 1 second, how much volume you're giving out, that is what we call FEV1. If you take a ratio between FEV1 and FVC, you see that usually in 1 second, around 93-94% of it is given out. And like minimum and all 83% it should be. 84% below, usually it has to be not there. It should be much above that. Okay, that is the normal setting. Now here you can see a person who is having obstruction. In an obstruction, what is happening? The person, when it's expiring and positive intrapleural pressure is happening, that will collapse the smaller airways. Or the person already is having some sort of collapse in the smaller airways, some pathology. Because of which, now the rate of flow is going to be different. Difficult for it to go, more airway resistance will be there. So it cannot move that fast. If you see that, it'll take a longer time for it to reach its FVC. If you look at the percentage, during the first 1 second, the person was only able to eject 50% of that FVC, only half of it. Here, around 83% was. This is one classical example of an obstructive lung disease. Instead of that, you see another scenario where you see that the vital capacity has diminished. That is what happens in restricted disease. Compared to the normal, can you see the normal? Compared to the normal, this much vital capacity is there. Instead of that, what will happen? The vital capacity is reduced. But yeah, FPV1 by FPVC ratio is pretty much similar or can even be higher. That is what you see in a restricted disease. So this can help you understand this. Apart from that, a pressure volume loop can also help you understand. Normally a pressure volume loop during expiration, this is the peak expiration, and further on the rate slows. This is the flow rate. In airway obstruction, what will happen? The peak expiratory flow rate will be lesser. And it will never reach till the residual volume. Before that, air trapping, this much of air will be trapped inside. But in a constricted lung, you're inspiring from here, maximum vital capacity will be this much. Not, it won't go here, it will not go extra, instead it will be here. So in chronic obstructive pulmonary disease, two things happen. One, emphysema, the other one is chronic bronchitis. In chronic bronchitis, what is happening? Inflammation and excess mucus secretion, because of which narrowing happens. And apart from that, in emphysema, what will happen? These alveolus, the connective tissue surrounding it, because of problems over there, they'll become thinner and thinner. And although they can, inflate much more easier, they will also collapse much more easier. So they are more prone to collapse, especially during expiration. So you can see here, normally, your airway, less than 2 millimeter diameter, this airway, the resistance, this is the value of resistance, is around 0.3. But in COPD, this resistance will go up to 12 times, 3.5, as you can see here. Rest of it, not much different, but especially this. Okay. In asthma, what happens? Some sort of trigger should be there. From pollen, some sort of trigger. In these people, usually the airways already has some bit of narrowing because of inflammation. Now, when a trigger is happening, that will suddenly lead to spasm in that already narrowed airways and can result in asthmatic attacks. So it's all sort of obstruction. This obstruction is mainly affecting your expiration. So hypersensitive bronchioles in reaction to certain substances like histamine, slow reacting substance of anaphylaxis, bradykinin, eosinophilic chemotactic factors can all result in edema and spasm. Now, there's another thing that I want you to see. Look, take a look at this normal CT scan. Now, on the right side is a CT scan of a particular lesion called interstitial lung disease, where mass scale of fibrosis is happening all around. This is a type of restrictive lung disease. Restrictive lung disease can be of two types. Either it can affect the parenchyma, like the interstitial lung disease, or some sort of tuberculosis, silicosis, and all that. Or it can be outside, where restriction to lung movement is happening, like some sort of skeletal abnormality, muscle problem. So kyphosis, scoliosis, ankylosing spondylitis, or neuromuscular problems where polio is there because of some drug overdose like barbiturates. The person is not able to move the chest wall much, or rib fracture, again, not mechanics is affected some way by some external factors, that is extra parenchymal, or inside the lung some abnormalities that is parenchymal. These are both examples of restrictive lung disease. Examples of your obstructive diseases are COPD, asthma. Under COPD is emphysema, bronchitis. So sometimes if they ask emphysema, what type of disease is it? Don't get confused. COPD includes emphysema as well as chronic bronchitis. So let's try to understand why you have to choose Auricle. Because Auricle's got a lot of foundational classes which are made available. Your full description of all the chapters are there. I personally done around 100 hours of pre-recorded sessions. live classes, you can always, check it out and interact with the teacher and get the feel of actually being in an exam, in a classroom. Express exam module helps you out, especially just before the exam, in order to study specifically for the exam. So the whole syllabus can be covered in less than 20 hours. And we'll be talking about important questions and things you have to take into special consideration and focus on. There is also one-to-one doubt clearing sessions, and hard copy notes are also there. So this can help you ease and have a better way to study. And you can use the question banks, which has different types of MCQs for different difficulties. And of course, the practical sessions have also been pre-recorded and will help you out greatly for your exams. So right now, these are the various subscription plans which are made available. You can use my code Dr. Shakthinag 20 for discount on subscription. Thank you for watching, and you can visit any of the social media handles in order to contact Team Auricle. So thank you.